Our objectives today is to understand each part, each phase of the polysomnography, all the way from the referral to the reporting. And then we'll talk about the different protocols for adult pediatric patients and how we will apply the AASM criteria, AAST recommendations, and VRPT best practices in clinical sleep medicine. And then we'll summarize some parts of the troubleshooting, scoring, clinical management steps. The whole idea for today's class is for us to understand the entire process of a sleep study from the patient's journey, in fact, from the beginning all the way to the end. Okay. In this way, we'll try to understand all the fundamentals, all of the pillars, all of the necessary steps on how the patients get seen in the beginning and all the way to getting their clinical management. All right. So on that note, first and foremost, when you step into a sleep lab or a sleep clinic or a sleep center, the first thing we need is the referral. Everything starts with the documentation. Who is this patient? Who are our patients? So it starts with a referral. Before that, the patients typically experience some form of pain, discomfort, can't sleep, always tired, have issues snoring, right? The spouse is complaining, etc., having headaches, seizures, etc. So it's all about the patient being symptomatic. And then they start to complain. They'll talk to their primary care physicians or their nurse practitioners or their specialists. So that's the first step before they get into a process. Once they express their complaints, then that's when a sleep doctor or a primary care physician assistant, nurse practitioner, then they collect this information and they will come up with a referral that this patient has sleep-related issues. Therefore, I'm going to refer this patient to a sleep clinic. So once that happens, there is a necessary or a mandated activity that needs to happen, which is to get authorization. And this is, of course, a big part in the United States healthcare system. All right. So in the United States, you can't just be seen from one clinic to the next without going through an authorization process, simply because we have insurance that pay for these services. In the Philippines, for example, you do have PhilHealth, you have HMO, and you have private pay insurance companies. It's also evident there. However, it's not as robust or it's not as streamlined compared to the United States. Here, it's mandated to have insurance. So before a patient goes from a regular clinic or specialty clinic into sleep, there it requires an authorization. Once the authorization is acquired, then the sleep clinic, who is the accepting clinic for this patient, will now process this patient. This patient will then be scheduled for a visit to see a sleep doctor or a sleep provider. Now, why do I say sleep provider? It's because here in the United States, we have sleep practitioners that are nurse practitioner, physician assistant. We also have PhDs, like psychologists. These are not MDs. These are PhDs in psychology, but they have gone through training and fellowship in sleep medicine. So you always hear me say sleep providers instead of sleep doctors, sleep physicians. Okay, other types of practitioners, or we call them APP, your advanced practice practitioners, they are allowed to see specialty patients such as sleep patients from initial visit to authorization to now the sleep clinic. And they'll go through the process of identifying whether this patient requires a sleep study. What type of sleep studies do we have? Do we only have one type of sleep study? No, we have overnight sleep study. And what's the other one? We'll open the chat. What's the other one? What's the other type of sleep study? It's the home sleep testing, correct? Yes, good. So home sleep testing, there is a gamut. There's a lot of types of home sleep testing devices. It can go from a bulky device into very miniature one. You even have now wearables like the Oura Ring and all that, Sleep Image. They're very tiny devices, but the Oura Rings, I'm sorry I mentioned that, those are still considered wearables, whereas the Sleep Image is also a ring type of device, but it is considered a home sleep testing device. The decision is made by the initial clinic visit where whether the patient needs an overnight sleep study or a home sleep testing, or maybe not at all. Some patients complain about insomnia. So insomnia, if the sleep provider assesses the patient and realizes that this patient really is not an apneic type of patient. It's more on the insomnia or even narcolepsy. But insomnia patients, typically they'll give them a diary, a sleep log, instead of pushing the patient to do a sleep study. Okay, so it's a different pathway. All right. Now, one quick question. Why do we differentiate whether the patient goes to an overnight sleep study versus a home sleep testing device? What's the major distinction, or why are we doing that? Anybody? Feel free. The question is, what makes the decision, what's the decision process where the sleep provider will decide to send the patient to do an overnight or sending the patient to do a home sleep testing? Why would they choose one or the other? What's the main criteria?
Patient can sleep in the hospital or depends on their comorbidities.
Good, very good. So the main decision is because one, home sleep testing devices are FDA cleared, right? These devices are cleared for obstructive sleep apnea only, right? They are obstructive sleep apnea devices to detect obstructive sleep apnea. Some devices now have more capabilities, such as identifying central sleep apnea. However, overnight sleep study patients, the one that will go to the sleep lab, have more wires. These patients have comorbidities. Typically, if the doctor or the sleep provider assesses the patient and notices that, oh, this patient had possible or diagnosed COPD, obesity, hyperventilation syndrome, heart failure, right? Maybe diabetes, type 1 or type 2, right? If these patients have comorbidities, they do not belong to home sleep testing. They need to be seen with an overnight sleep study. Okay, so you're right on the money right there. So if patients have comorbidities, overnight sleep studies. If patients is simply OSA, you go to do home sleep testing. If it's insomnia, you give them a sleep diary or sleep log. Clear? Now, after we confirm the referral type, diagnostic indication, then we ensure that we have all the documentations. We collect all the informations from the patient because we try to create now a patient profile and a patient record, right? We usually get the patient's medical history, family history, include all their medications, current diagnosis, previous diagnosis, any surgeries. Do they have families that have sleep issues or history of cardiovascular disease? Anything that relates to sleep medicine. Okay, we collect all this history. We also give them some of the most important documents in sleep, which is your ESS. What's ESS? It's the Epworth Sleepiness Scale, right? Epworth Sleepiness Scale. This asks about 8 questions regarding how sleepy a person is, and we have other chapters to tackle that. But just remember EPWORTH, Sleepiness Scale. All right, we give them the Stop Bang, STOPBANG, Stop Bang questionnaire. That's typically for patients that the sleep providers consider them to go for a home sleep testing. So usually For home sleep testing patients, you give them stop band and other questionnaires. And for overnight sleep study patients, you give them all the comprehensive questionnaire. You don't necessarily have to give them stop band unless the sleep provider is still suspecting that the patient might have some form of OSA. All right. So then we verify the physician credentials and testing authorization per facility protocol. Sometimes in the sleep clinic, we get orders, referrals coming from a primary care physician or primary care nurse, practitioner, doctor. By the time they get to the sleep clinic, it already states there that I want this patient to have a sleep study. But that's just a consideration. Who makes the call whether the patient needs a sleep study or not is the sleep clinic, is the sleep provider, not the referring physician, referring nurse practitioner, or the referring physician assistant. Okay, just to be clear, it's not the referring clinic to say what the patient has to do. It's the sleep clinic that will decide now whether the patient needs a home sleep testing, overnight sleep study, maybe just on oxygen titration, etc. Right? Now, we clarify any unclear orders before we proceed to the procedures. How we do this is that once the patient is seen in the sleep clinic, we have a lead tech. The lead tech will go over the orders, right? Because after the patient is seen, an order is created now for this patient to move forward. Then our lead tech goes over all the orders for the day, for the week. And as they go through the orders, if the lead tech sees that there's an unclear order, then the lead tech goes back to the sleep provider, whether it's your medical director or your sleep doctor, sleep psychologist, etc., and asks about the order to make sure that it's clear. Some orders are ambiguous, right? What does that mean? Ambiguous is not clear. Sometimes it says patient with BMI of 40 requesting MSLT. That doesn't make sense. Okay. So if a patient is so big, usually they have a higher tendency to be positive for sleep apnea. So if the patient is more than likely positive for sleep apnea, you would want to do home sleep testing or an overnight if they have comorbidity. So if the order is for MSLT or multiple sleep latency test, that doesn't make sense. So the lead tech now will go back to the ordering provider to clear the order before we actually schedule the patients. So it's a lot of process involved, right? Now moving forward. So we have to determine the type of sleep study. As we have already mentioned earlier, you have a diagnostic sleep study, which is an overnight polysomnogram with all the EEGs, EOGs, ENGs, snore, flow, EKGs, respiratory channels, leg movements, and pulse oximetry. We have a lot of sensors for this patient. And again, we have other earlier chapters that are recorded that you can watch and view to study that. So from diagnostic, we also have a split night study, right? A split night is you will do partial diagnostic and partial treatment or titration. Again, how many hours do we need before we can start the treatment portion? Anybody? Take a guess.
2 hours of TST.
Very good. 2 hours of total sleep time. So there is total sleep time versus total recording time. Total recording time is just the time from when you start the sleep study, when you hit lights out, all the way to the time that you hit lights on. That entire recording is total recording time. However, even if you recorded for, say, 10 hours, it doesn't mean that the patient was asleep for 10 hours, right? There'll be arousals, there'll be wake periods. So the total sleep time is less because total sleep time is just extracting the exact amount of time that the patient was actually sleeping. So total recording time versus total sleep time. In a split night, you have to have at least 2 hours of total sleep time before you can initiate the treatment. And typically, when a tech is looking at the diagnostic portion of a split study, they look for events and they look for sleep apnea, right? They count to make sure that this patient has a severe sleep apnea before they go for titration. If the patient only shows mild to moderate sleep apnea, and then the CPAP titration will not happen. It will continue as a diagnostic study. So even if the order is for a split night, it doesn't mean it's going to happen. It depends what happens with the patient. Okay. Now you have diagnostic testing, you have split night testing, and you have titration or treatment testing. Okay, so that there's three types already that we're talking about. When it comes to treatment or titration study, you can start with CPAP, you can start with bilevel, some will start with ASV or adaptive servo ventilator. And it depends on the case. And I also added VAPS. This is probably the most advanced, most sophisticated modality in titration for sleep studies. But then there are also patients that will come in, get evaluated, and all they really need is a supplemental oxygen titration. They will be wired up with a full setup, and then the tech will just initiate oxygen. Okay, 1 liter all the way to 5 to 6, right? To review, what's the maximum supplemental O2 that we can give the patient in a sleep study? Anybody? Up to 5 or 6, right? That 5 is good enough. We don't go beyond 6. Maximum is 6, right? I've never titrated above, say, 3 or 4 in my entire career. Because if patients require so much supplemental oxygen, they do not belong to the sleep lab. They require more ventilatory support. They probably need a ventilator. Now, I also put there OAT. What is OAT? Anybody know what OAT means? This is oral appliance therapy. So these are your inserts in the mouth. They look like mouth guards, but when the patient put it on, it moves the chin forward. So it's an oral appliance therapy that we can do during a sleep study. Sometimes I get an order where I will start the study with a diagnostic setup only, and then halfway through the night, just like the regular split, I will add the oral appliance and then continue the study. That way, the doctor or the reading doctor will compare the diagnostic portion versus the portion where the oral appliance is being used. Did it improve the apnea index, the hypopnea index, or not? All right. And then you also have MSLT or MWT. MSLT is your multiple sleep latency test. Again, multiple sleep latency test, or MWT, maintenance of wakefulness test. These two studies are done during the day. Okay. And then another type of sleep study is home sleep apnea test, or HSAT. Sometimes it's called HST, home sleep test, or sometimes it's called OCST, out of center sleep test. Okay, so it has a couple of different names. Anyway, now we talked about the 5 different types of studies that we perform in a sleep lab. Any questions? Let's move forward. So what do you do after you've gone through the records? Now we're going to look at the pre-study preparation. We look at the patient's chart for comorbidities as soon as you get to the sleep lab. You check for comorbidities. Does this patient have COPD or CHF? Because if the patient has any of these comorbidities, what are you going to do? Are you just going to read it, or does this help you prepare for other stuff? If you see that your patient has COPD or congestive heart failure, what does that make you do? Any ideas? So you're more than like, go ahead.
Check if they are clear to do sleep study.
Good. What else? So check if they have the consent forms, that they're clear. Meaning, if I see what you're getting at. So for example, COPD patient, right? What if this patient was just in the ER the day before, will you take them into the sleep lab just one day after? Yes or no? No. If the patient just came out of the ER or ICU, they have to be cleared for at least 30 days. They have to be stable for 30 days before they are actually booked in a sleep lab. Got it? That's a possible test question. If your patient has COPD or CHF, expect to prepare supplemental oxygen. Okay? And if you see that the patient has seizure disorders diagnosed, so you have to prepare for fall precaution, right? Or seizure precaution. In a sleep lab, you usually will have your hospital beds that you can raise the side rails, right? If the patient ends up with seizure, then you can at least have the patient be more safe by pulling up these side rails, right? And not just the side rail, usually we have seizure pads. So you pull the side rails up and then you put the seizure pads. If you don't have seizure pads, you just add pillows so that if they are seizing, they're still safe. They're not hitting their head against the metal side rails. But again, seizures, there are many types of seizures. At least there are 3 to 4 major types. The old categorization for seizures were grand mal and petit mal, right? Those are old terms. What we have now, current, are your generalized seizure, complex partial seizure. These are your newer categories. All right. So now that you have reviewed the charts and you have ensured that the patient already signed their consents, when a patient goes to a sleep lab, they sign consents that they allow for the sleep lab to record them. Because usually you will have your audio and visual recording, correct? So they have to sign that waiver, accepting the fact that they're being recorded. And some forms also ask the patients to give them consent that their study could be shared. For example, I had a sleep lab in FEU, Far Eastern University in Fairview, and some of these cases are talked about in the department, right? So when you share information about a patient, the patient must give consent, okay? Because these are their personal information. Usually these are protected information. Especially here in the United States, we're very strict with sharing patient information. So we have a law about this, HIPAA, right? And we'll discuss it in other chapters about documentations, okay? Now there's other forms. There's a bedtime questionnaire, also called a pre-study questionnaire, and there's a morning questionnaire or a post-study questionnaire. And so you also have the stop bag, Epworth Sleepiness Scale, Stanford question, functional or FOSQ questionnaire. There's so many different questionnaires in the sleep lab or sleep center. We have another chapter that we talk about. So you're reviewing the charts, you ensure that all the documents are there, and then you assess for contraindication, right? If the order says the patient must be titrated for the night, you make sure that they're cleared for any contraindications for PAP therapy or oxygen use. So what could be a contraindication for a CPAP? Anybody? So don't be shy. If you have an idea, say it.
Pneumothorax,
Very good. What else?
increase intracranial pressure.
Yes, I see. So any patients with head trauma, very good. Because when you put PAP therapy, what do you expose the nasal cavity to? It's like additional pressure, right, from the PAP machine. So if they have any form of damage or skull fracture or anything like that's definitely not a go. So another one is like low blood pressure. Okay. So if a patient has low blood pressure or hypotension, they cannot use PAP. Why? Any ideas? So PAP therapy, CPAP, bilevel, ASV, all PAP therapies, what they do is they drop blood pressure, right? There's clinical evidence that can drop blood pressure from 10 to 20 points in just 1 or 2 nights of usage. So if a patient already has hypotension and then you put them on PAP therapy, they can drop further. So you don't want to do that, right? You can kill the patient. And then, of course, there are those with maybe severe O2 or any other reasons why you will not use oxygen, or at least you have to be careful using supplemental oxygen. And then lastly, prepare equipment for the study. We perform calibration and we make sure that we create a backup storage. And this is important because it gets to a point where you have so many sleep studies in that hard drive. If you're not paying attention, you have the patient set up, you're ready to go, and then you start recording. And then what happens to the device? It stops. It will not allow you to record because the hard drive is full. So this is very important for a technician's perspective. You always have to check if your equipment is ready for recording. Meaning to say, you also have to make sure that the device have enough space to record. And typically, you will require 1 to 2 or to 5 gigabytes, right? Because we also have video recording, and that eats a lot of memory, all right? At least for the ROM. There's RAM versus ROM, all right? It gets technical, but we, the techs, need to know this part. That's why we're called technicians or technologists, right? We need to be aware and know exactly what to do when it comes to our equipment. All right, let's move forward. Now, room and equipment setup. Now, we set the room before the patients get there. Some sleep labs are in a hotel. For example, I work for a medical university. So the university has a school side and it has a medical side, the hospital area. And we have our sleep lab. It used to be in a hospital. And then what happened was they moved us out of the hospital. I moved the lab, which is just maybe a 2 to 5 minute walk from the hospital. We moved it to a hotel. But then the hotel is very comfortable, good lighting, good noise control, better than hospitals, right? Because there's no overhead announcements, etc. But anyway, you have to make sure that the rooms are comfortable, temperature is good, because people cannot sleep if the temperature is hot, uncomfortable, humid, right? So typically sleep rooms have AC. You can't have an uncomfortable room because you're trying to have the patient fall asleep. Right? Lighting is very important because if your light is not dimmable, like my light right now, I can dim and I can make it brighter, right? It helps because you're trying to set the tone, the mood, and it helps the patient regulate their sleep, in fact, right? And we'll discuss more about that in other chapters when it comes to the effects of light. In fact, I did discuss that a couple of weeks ago when we talked about circadian rhythm disorders. Anyway, you set up the room, right? You ensure that everything is safe, that you don't have any equipment that has frayed wirings, right? Some wires that are about to snap. We are in charge of that. Okay. We also make sure that infection control is applied, right? We can't be seeing dirty linen, right? Or unsanitary looking rooms. There's blood spills on the floor. No, like that, those are unacceptable. Especially now after COVID, we do extra to disinfect the rooms. In the hotel where I work at, it's the housekeeping that does all that. In the other sleep labs that I worked at, I was doing the disinfecting. We wipe the rooms with Cavicide wipes, right? Cavicide wipes has what this chemical called glutaraldehyde is a high level disinfectant. It's what you need. In fact, that's a test question for those that are reviewing for RPSGT. Glutaraldehyde is the most important chemical for high level disinfection. So we wipe the rooms, we wipe the beds, the tables, the chairs, the doorknobs, disinfect rooms during and right after COVID. And then we check if the video and the AV, right, audiovisual, the intercom is functional. Okay, we do that usually with the patient calibration. And then we verify all channels and the sensors once we have the patients connected to the sensors, right? And then we connect all the wirings to a head box. The head box is connected to the amplifier. The amplifier is connected to the computer. Okay, and from the computer, it's connected to your monitor so you can see everything. All right. So we check from one point from A to Z. All right. That's our job as sleep. Of course, it all sounds very daunting, overwhelming, right? But it's not. Once you start to work as a sleep tech, or if you are already working as a sleep tech, you know that this just goes very quickly. This is not even, you're not even really spending that much time doing this. This becomes automatic with muscle memory. All right, sensor and electrode application. We follow the AASM guidelines of a system called the International 1020 system. And that's one of the very first chapters in this course. There's a video available for that. You can even see it in YouTube anywhere, but I taught that as well at the very beginning of this course. So that's when you properly measure and mark the head where you're going to place the electrodes so that you can have precise information that you'll collect from the patient. Okay. And you maintain the impedance. So when you record, you measure how much of a resistance to the flow of electricity that will come into your sleep system. In short, if the impedance is high, that means the resistance to the recording is high. Your recording is hard to read. It will be blurry. It will not represent a clear data. So if you lower the impedance, right, if you lower the resistance, and it's measured in kilo ohms. If you lower that, your recording will be acceptable. It will be very readable, very clear. And that's by using appropriate techniques in scrubbing the head, right, with a prep solution. Some sleep labs use alcohol. Some sleep labs will use new prep or lemon prep. They're a little like salt. So it takes out the old skin, oil, natural oil of the patient. When you do that, you clear the pathway, the information going from the patient's brain or the head to the muscle activities, to the flow, mainly just from the EEG and the EOG, and also the EKG. It will be clear. They will have less, if not zero, artifacts. All right, so that's impedance or resistance. And then we apply all the other sensors, including pulse oximetry. For pediatrics, what's the additional sensor? Anybody? What's the additional sensor for pediatrics? We do EtCO2 or TCCO2. Yes, this is very important. If it's available, you use it. It's expensive, so most sleep labs don't use it for adults. Only if the patient is suspected of having hypoventilation syndrome, like a Pickwickian patient, like morbidly obese. So if the patient comes in very big, the doctor usually orders additional parameter, additional sensor, which is EtCO2 for the most part. So it's additional cannula to monitor CO2 because the transcutaneous CO2 monitor is expensive and we use it usually just for pediatrics. Because when you use TCCO2, you have to replace it midway the study. So you spend a lot. All right. Patient orientation. Now, when patients come in, you don't just put them in the bed. Okay. You have to make sure that you educate the patient. In fact, one of the biggest and most important jobs that we have as sleep is patient education. From the time they walk into the sleep lab until they leave in the morning, we are educators. We teach them, we inform them, we orient them. Okay. And one of the most important thing is that why do we do that? One is for patient information, but the other thing is for patients to feel comfortable. All right. When we teach them, we show them that we are capable of what we're doing. We know what we're doing. They are in good hands. They will then relax and be compliant with the therapy, with the study, etc. Okay, but we do orient the patient. Here's your room. There's the restroom. If you need any water, you let me know. I will sit here. This is the tech room. This is where we record you. There's a camera. So when you change, use the restroom so that you're not exposed. So things like that. We orient them where they're at. Okay. And if you orient them, you also make sure that they know that they can reach you. Usually we'll have a call bell where they can press and reach you, or they just talk because we always have an audio visual setup in each room. They can just talk and say, hey, tech, I need to use the restroom. Then you get up there and unplug them so they can use the restroom. They need to know this. This is very important. The more the patient is oriented with what's happening from the time they came in, all the time by the end, also by the time they leave, if they are well oriented, well informed, then they are more compliant, they're more relaxed, and they can give you a better sleep study. And then, of course, if they are there for treatment or titration, you have to demonstrate how to use the PAP masks. You'll give them an option whether they prefer to use a nasal mask, a nasal pillows mask, a full face mask. And then we make sure that they're comfortable. We address any other anxieties that they might have. So sometimes they have all these worries. What if I want to use the bathroom or I'm uncomfortable? Can I move? So you have to engage the patient to make sure that there's nothing that they're worried about that you have not addressed. Okay, especially for the elderly, elderly with Parkinson's, elderly with Alzheimer's, elderly anxious patients, or pediatrics. Pediatrics typically, it is mandated that they have a caregiver or their parents or guardians with them. You will never record pediatrics without anybody else there. But still, you have to engage them and make sure that they're very comfortable, especially pediatrics, because they can give you a hard time. And then lastly, we usually take their blood pressure and oximetry at the beginning, right? And any complaints. Do they have a headache? If you have a patient and that they have a history of heart attack or stroke, and they are on heavy blood medications or heart medications, sorry, then you have to make sure that they're not experiencing any symptoms, correct? If they're experiencing any symptoms and they have a history of cardiovascular disease, you do not proceed to perform a sleep study. You call 911 or you escalate it and call your medical director, right? And ask what to do with this patient, unless you have a clear protocol that's written on what to do with particular patients. But if any patients are symptomatic where it can lead to an emergency, you do not proceed to perform a sleep. And if they have any complaints such as headache, runny nose, etc., you might want to address that, right? Some labs have Afrin or nasal sprays available, but others you will allow the patient to use their own medications. Okay. If you're unsure, you call your sleep doctor or you read your sleep lab protocol. Questions before I keep going? How are we doing? Anyway, moving forward. Now, pediatric versus adult patients. There's different approach. Chapter 1 is in fact age specific. Age specific is that chapter teaches you on how to perform sleep studies with particular types of patients. But then we'll just review it. For pediatric, we use age appropriate communication. You will not be technical, you'll not be clinical or medical to these types of patients. In fact, the younger the patients, the more playful your approach will be. And some patients that are tiny, you cannot speak to them directly. If some are too shy, you have to talk to their parents first or their guardian, then before you talk to them, because they usually take cues from their guardians to see if is this person safe to talk with. So it's a different approach. There's a lot of gamification involved and so forth. Now, you also have to adjust the montage and how you have the sleep study is being recorded. Montage is how it's laid out. How are you looking? Are you looking at the EOGs on top, EEGs at the bottom, respiratory channel after that, or leg monitors after? That's montage on how you are arranging your different channels, okay? But there is a pediatric montage, okay? And then adult, you address some of the lifestyle issues. Some adults, they will not sleep until they smoke. Who had those patients? I've had them. I had a patient, I used to have a sleep lab in Tagaytay Medical Center in Tagaytay, and some of those patients, they need to smoke. And at one point I had a patient, he smoked and talked my ears because I accompanied him. He talked until almost midnight. So I had to tell him, hey, we need to go. He was smoking, chain smoker. Just smoking after that, I had to let them know that we have to start a study. But in other labs, they're only allowed to smoke once. And typically you have to have 1 to 2 hours or at least 30 minutes from the time you start lights out the time you start your sleep study, right, from the time they smoke, okay? Because smoking, what does it do? What does it have? Nicotine, right? Nicotine, I discussed it in pharmacology yesterday with chapter 23. Nicotine, it has awakening effect, not a sleepy effect or a sedative effect. So anyway, some patients also are known alcoholic. They're undergoing treatment. So some of these patients cannot sleep without drinking alcohol. Okay, so these patients are allowed to have alcohol in the sleep lab. They are allowed if they are known and diagnosed alcoholics. Because if they just stop drinking alcohol all of a sudden for the sleep study, they will have withdrawal symptoms. When they have withdrawal symptoms, they will not fall asleep. For those taking the RPSGT exam, will these patients be allowed to have alcohol? Yes. And medications. Many patients have different medications. They're allowed to have medications. Their regular dose and their regular time that they take their medication. But except for medications that affect your sleep. So typically, any medication will affect the patient's sleep. They are cleared by the sleep doctor ahead of time or the sleep provider. And lastly, geriatric. So account for any comorbidities. They're more fragile. So you have to be careful when you scrub their heads when you're putting the electrodes. You have to be careful if they pee on the bed, right? Same thing for pediatrics. Usually you can buy this pad, right? It's a waterproof pad. You put it on the bed before you put the linen, or you put your bed sheet and then you put this pad and then you put another sheet on top before the patients lay down. So if they end up having any incontinence, you don't really mess the bed. And then cognitive impairment. Some patients have severe dementia or at least dementia, and these patients require assistance. They need to have their family members or their caregiver because some of these patients, when they wake up in the middle of the night and they are lost, they can freak out. They can start screaming. They can try to run away. They're afraid and they're very anxious. So it helps if they have a company in their rooms. Just make sure that whoever is accompanying them in their sleep study is not a loud snore or have apneas themselves, because that will just ruin your sleep study. All right, we're getting there. Now, usually when we do lights out, when we start a sleep study, we go as close as possible to the patient's bedtime. Many patients, they will sleep between 9 and 11 p.m. But some patients are late sleepers. They go to bed at midnight, 1 a.m., especially those that are retired or that they have shift work. They don't have a good SIMS or a good habitual time in bed. But what we do is we try to get close to that. However, since techs are limited in their working hours, we can't really go as far as like midnight or 1, 2 in the morning, because then we can't finish their sleep study because we have to clock out and leave the hospital, leave the sleep lab. Next is we record the calibration. We do calibration with the machine itself to make sure that everything is running and are able to record. Then we do a patient calibration or bio calibration. This is when we have the patients already wired. They are laying down in bed and we are recording, but we are checking if all of the sensors are working properly. We usually ask the patient to open and close their eyes. We ask them to grind their teeth so that we can see if all these activities are in fact showing on our screen. We ask them to hold their breath to imitate an apnea. We ask them to snore, flex their leg, etc. Okay, that's called a patient or bio calibration. If there are anything that needs to be fixed, this is the time that we fix. Okay, maybe their electrode popped off or came off or broke, right? So you have to go back in there and fix it. The reason being is that you want to reduce all of the troubleshooting when you are already recording. Okay, when you try to troubleshoot in the middle of the night, that will affect the patient's sleep efficiency, right? It will affect the patient's wake after sleep onset, or WASO, recording, etc. So you want to make sure that your recording, your sensors are robust, solid. You take them as you secure them properly. All right. And sometimes some of the patients are more sensitive, so they'll tell you, oh, this electrode here is pulling on my hair. or skin. So you fix that during this time. And then you document any notable events. Do you see patients' leg movements while they're sleeping? Those are important. Is this patient constantly waking up out of nothing? Because they can have arousals, and arousals could be because of snoring, apnea, right? Or movement arousals, or spontaneous. They can just easily wake up. Or maybe a fire truck came by and it's so loud. So the patient woke up. You have to annotate that into the recording. And then, of course, we monitor and document respiratory events to the sleep apnea, obstructive apnea noted, central apnea, hypopneas, or rarest respiratory effort related arousals. Troubleshooting. When you see a flat EEG trace, you have to go back in there, fix the electrodes. Maybe the EEG channel's already connected. I have a completely separate presentation on troubleshooting and artifacts. So I won't go through this deeply, okay? But there's electrical artifacts, EKG artifacts, there's salt bridge, respiratory artifacts, sweat artifact, okay? And so if you don't see any flow signal, maybe the thermistor broke or came off. So this typically, the patient get annoyed because of the thermistor that has those two little prongs and they pull it off or they itch their nose and it comes off. So you have to make sure that you put it back in. The quicker you troubleshoot, the quicker you fix the problem and the quicker you're out of the patient's room. You want to be in and out quickly. You don't want to linger and stay in the rooms because that will start affecting the patient's sleep efficiency. And then if you see that there's the patient, as you start the study and the oxygen saturation is 50, 70%, you don't just assume that the patient is having desaturations. You go back in the room and troubleshoot. Ensure that the finger probe is working properly, that you see the infrared light. You might also reposition into a bigger finger and you tape it so that it's secure. All right. And sometimes the patients, especially geriatrics, are cold. If their hands are cold, you cover them, make them warm, and maybe you'll get better reading or more accurate reading. And then excessive leak during PAP. You cannot continue titrating the patient on CPAP bilevel if the leak is super high. If the leak is high, you're not effectively treating the patients. Then this can lead to false or inappropriate pressure. Split night studies. When you start the sleep study again, we mentioned it earlier that you have to have at least 2 hours of total sleep time. And then if you have at least 2 hours of sleep time and you assess and calculate that the patient's apnea index is severe, whether it's over 30 or over 40 per hour of apnea hypopnea index, then you can start your CPAP titration. Usually we start with CPAP titration, otherwise directed by the sleep or provider. You have to prepare for the mask ahead of time before you even start the study. You have to use a couple of different masks, ask the patient to test it out so that you're not putting this mask on the patient without them having experienced this at all. They could freak out if you wake them up at midnight or whatever time, 1 a.m., 2 a.m., and then all of a sudden you place a mask on their faces with the pressure. You have to break them in at the beginning of the night. In fact, this is one of the first things I do. The patients arrive, I give them their paperwork, I take their vital signs, and then I let them test a mask with pressure. Okay, just to ensure that they're able to tolerate it if I need to apply it in the middle of the night. Okay, and you also calibrate the pressure. You increase the pressure until the apneas and hypopneas and desaturations are all resolved. And again, each increase in pressure, you document. All right, that was a lot. I'll stop right now just for a quick pause. Any questions? Ladies, gentlemen, any questions? All right, good. Let me continue then. 3 more hours to go. Just kidding. I know it's late in the Philippines. All right. So what are PAP in advanced modalities? Most of you are RTs and some are nurses. I don't know the other backgrounds. Okay. But majority of the time we start with CPAP. Majority of the patients that undergo sleep studies have CPAP needs. Okay. So continuous positive airway pressure. versus some will progress to a bilevel pressure. And this is because they need pressure support or they need something more comfortable than CPAP. Here in the United States, patients are allowed by their insurance companies to use a bilevel if they cannot tolerate CPAP. Okay, but we can't just apply bilevel because the patient wants it. No, it has to come from an order and it has an algorithm. CPAP, you try CPAP first. If the patients still have apneas and you have a pressure of 15 centimeters of water pressure, right? And they're still having apneas, you can convert and switch to bilevel. That's one pathway. And this is under the guideline from the SM. Okay. We follow ASM all the time, the American Academy of Sleep Medicine. All right. Now, the other way you can move the patient from CPAP to bilevel is if they cannot tolerate the pressure anymore. If you have them at 5, they're okay, 6, 7. Then when you get to 8 centimeters of the pressure, the patient pulls out the mask. I can't do this, it's too much pressure. Then you can switch them to bilevel. All right. That's one of the other pathways. Then you have patients that develop or have central sleep apnea. And these patients, even if you use a backup rate, if they have central sleep apnea and you add a backup rate, it will only exacerbate the central events because of the pressure support. And I have another chapter about titrations that's available, but we can also discuss that. However, ASV alone is at least an hour to 2 hours of discussion. But ASV is what treats this patient more effectively. In fact, I'm right here. I have central apneas as well as obstructive, and I am what you call a COMPSA. The other term for COMPSA or complex sleep apnea is TECSA, treatment emergent central sleep apnea. Meaning to say, some patients may start with obstructive apneas, but as soon as you initiate your CPAP titration, as you increase, their centrals emerge, right? Therefore, treatment emergent central apnea. As you increase pressure on CPAP, you switch to level, you increase pressure, they're still having centrals, you add a backup rate, they're still having centrals. These are your TEXA patients. You have to convert them into ASV. ASV has a very sophisticated algorithm. It treats the patient's central apnea by monitoring their minute ventilation or their peak flow. So I have a totally separate discussion or presentation on that because it gets into the nitty-gritty of the algorithms. It's very exciting because it's the device I use, right? That's for your central apnea patients. And then you also have VAPS, volume assured pressure support. I didn't put the slide in here because that's a whole nother complicated discussion or long discussion. However, since most of you are RTs, I don't see any issues that you guys can pick it up. And then you have oxygen titration, right? Some patients come in, they are on long-term O2, and the doctor wants to ensure that they get on the appropriate level of O2, supplemental O2. Some of these patients just use O2 when they lay down and go to sleep. And some patients will require 24/7 O2, right? But these are your patients that are not supposed to be on a ventilator yet. That's why they'll do a sleep study because when patients are already that severe that requires higher O2 titrations, then they don't necessarily need a sleep study, but they require mechanical ventilation that most of you can help these patients. Okay. And the main goal is for these patients to have above 90% saturation. All right, getting there. Monitoring through the sleep study. When you are running the sleep study, some of the most important things that you have to do is, of course, annotate, right? Make sure that you observe for mask intolerance or leaks. Mask intolerance, sometimes the patients just hate or psychologically don't like something that covers their nose. So now we have mask that just covers the mouth and the nostrils, right? The narrows below here. Some patients are okay with mouth mask, but not okay with anything that inserts in their nose. So there's definitely a whole range of masks that are available now. And I have that presentation already in some of the chapters. But you have to be observant. You have to be aware of what can lead to this patient taking off their mask, right? The biggest enemy you have in the lab during titration is the leak. Okay, leak is your worst enemy in any titration. I just did a presentation 2 weeks ago, California Sleep Society meeting. I presented on algorithms and optimizing titrations. I'll be posting that in YouTube, by the way, and so hopefully you can get to watch it. But I reiterated again and again about leaks. Since we can't control leaks as much, we ignore it and we continue to increase pressure, which is a big one, right? The more you increase the pressure, the more you increase the leak, and you're not really treating the patient. Okay, you have to remember that. By the time you finish, the patient will use this machine every single night. And if the doctor writing the prescription has a wrong prescription because of so high of a leak, that means this patient will use a wrong prescribed device. Now, maintain communication is you always make sure that the patient knows you're there if they need you, but you don't just talk to the patient in the middle of the night, right? You make sure that they're aware you're there. You test the patient's audio and visual communication back and forth at the beginning of the night so they can get used to calling out to you, okay, to make them feel more comfortable. And then you also ensure that the video and audio and all the physiological data is continuously recording. Sometimes the system will stop, it will just freeze. And sometimes you'll need to reboot the system. When you have to reboot the system, you have to unplug the patient first. You go to the patient's room, all the wires are connected to a head box. You unplug that head box. You go back to your tech room, restart the system. You never reboot the system with the patient being plugged into the system. Okay? That's a big no-no. In fact, that's an exam question. All right, finishing the sleep study. When you start a sleep study, it starts on lights out or lights off. That's when the study officially begins. Even if you are troubleshooting, recording the patient, the main thing is when you first hit lights out to lights on. In between, that's your entire official recording. Okay? So make sure that sometimes they forget to hit either the lights out or forget to hit the lights on. And so if you forget to hit any of that, the machine or the computer will have a wrong report because it cannot calculate appropriately, right? It cannot do all the calculation of the apnea-hypopnea index, the average or the mean. All these recordings will be off because of not having the lights on. You have to have those two markers. All right, and then you talk to the patient about anything that they need to discuss or tell you. You also give them the documents, the post-study questionnaire. And then you clean the equipment, clean the electrodes, etc., prepare it for the following night. If there's any blood spills for some reason or any patient peed on the floor, you have to call housekeeping. You make sure that everything is done appropriately according to your policy. And then you make sure that the data is being backed up. All of the recording has to be backed up because you don't want your data to be corrupted and you don't have any other backup. So we always have a server, whereas as soon as we finish recording, it's automatically backing up the data to a server. In one small lab that I work for, I did it myself. I asked the doctor to buy me an external hard drive, and then every week I back up the data. And after I back up the data to the external hard drive, I delete it from the actual computer. So I maintain a big enough space to keep recording properly. All right, scoring. So when it comes to scoring, we only follow ASM guideline, American Academy of Sleep Medicine. The current is version 3.0. How do we score N1, N2, and REM? It's in every 30-second epoch. We always highlight any apneas, hypopneas. REM, respiratory effort related arousal, are now hypopneas. So it's not rare. We don't really highlight rarest per se. We just highlight hypopneas. And of course, I get into that in another chapter. PLMS, periodic limb movements of sleep, and also arousals. Okay. Then after we highlight these events, the computer will calculate what is the apnea hypopnea index, respiratory disturbance index, cardiac movement index, sleep efficiency, total sleep time in bed, and many other parameters. It's recorded. All right. Quality assurance. We always have to make sure that all of the epochs tagging are all correct. And usually these things are done by the day tech or whoever is the lead tech or the lab manager, for example. All of you, when you work in a sleep lab, it doesn't mean that you will stay in the sleep lab working the nights. Many of you, as soon as you have enough experience and enough seniority, you move up to the day activities. In fact, if you can do that after a few years of working in a sleep lab, then it's better for you, better for your career. You can get into higher level of licensure, like you need to have RPSGT, but you can also get CCSH or Certified Clinical Sleep Health. And these additional accreditations or licensure will name you as more of a day tech, the lead tech, the trainer, the supervisor, okay, or the manager. Okay. So it's not all about working night shift. Okay, you can also move into the DME portion. DME is where the device are be given to the patient and the patient gets their education, their compliance are being monitored by the day tech. Okay, there's many other jobs, and I talked about this in another topic because I have performed any of these jobs. I used to be a night tech, lead tech, trainer. Now I'm a manager, but on the just mostly administrative portion. You can be an instructor. You can work for a manufacturer as a clinical specialist. You can work with the sales and marketing team. You can work for durable medical equipment, like you can go see patients and set them up with their sleep studies, their CPAP machines, etc. You can monitor their compliance. You can be a scoring tech. You can work in a sleep lab, and all you do is you score all the studies. So you work during the day. My wife does that for the VA, for the Veterans Hospital. And so you can even score. I have students who work for a US company, but they live in the Philippines. And what they do is they score sleep studies here in the United States, but they are living in the Philippines. It's a lot of different opportunities. So anyway, moving back to this, you verify the totals of the indices. In the summary report, you have your AHI, RDI, etc. You also have your hypnogram and histogram, where it will show the patient's overnight summary in a snapshot. And then you ensure that the patient's ID and demographics align with the actual patient you had. This happens. Sometimes the patients might have similar names, and then you didn't catch it until the end. Whereas you might have a Joseph Salvador, and this patient you had was Joseph E. Salvador. So they have similar names, but not the same exact person. These things happen every now and then. If you're not paying attention to details, it can go wrong. And it's a big problem because now some of these information are locked in and you can't edit it. And if it's already uploaded into the electronic medical record, it requires a few more steps before you can correct it. You have to go through other departments to provide them data that it is a mistake, that you have to delete that information from the wrong patient and upload it to the right person. These things might not look very important, but they are super, super important. Okay. Now, report generation. We're getting there. In a report, sleep efficiency is important. Staging, of course, N1, N2, N3 REM, right? Very important to be there. Respiratory indices, age, having apnea, hypopnea, central apnea, right? Or the saturation, leg movements, any arrhythmias, very important, right? These are all mandatory or recommended information to be in a report. Okay. And then it goes from this is after you perform the sleep study, diagnostic therapy, etc. Some patients will require to do a follow-up sleep study. Maybe the initial sleep study is inconclusive, right? So the patient was sent for a split night, and then you as a tech notices that there's no sleep apnea. But then this patient is still symptomatic. So what the sleep providers will do is to repeat a sleep study followed by a daytime study. Because now a PSG or polysomnogram is used as a baseline for the patient to have an MSLT or multiple sleep latency test to see if they have narcolepsy or EDS, excessive daytime sleepiness, or idiopathic hypersomnolence, right? They are not OSA patients. They are now more into the realm of narcolepsy, right? So you need a different study for that. You need a daytime study, which is the MSLT. But you don't do an MSLT without a overnight sleep study. So it has to be both. MWT, maintenance of wakefulness test, also a daytime study, but it's for a different purpose. And I've discussed that in chapter. Lastly, when all these things are done, it ends up on the physician's desk. What the physician will do is to interpret the study and correlate the symptoms and then create a diagnosis, clinical management, whatever you're going to do with this patient. And I mentioned here physician because there is no other type of professionals that will read sleep studies, only sleep boarded physicians. No nurse practitioner, no physician assistant is boarded to read a sleep study. However, PhDs or psychologists are allowed to interpret and read sleep studies. Okay. So you have a MD and a PhD. They can read sleep studies. More important elements in a sleep study report. Again, patient identifiers, name, date of birth, social, and the study type, and then the summary. What does this patient have? Do they have sleep apnea? How much REM do they get? Do they have good sleep efficiency? Sometimes the patient just requires an adjustment in their sleep hygiene. Okay, so some patients are always sleepy because they just have bad habits. And this is where the sleep providers will create a report and then recommend for this patient to do the following, right? Maybe they find out that in a sleep study, they were normal in saturation, no apneas, and REM was a little off or whatnot. But then come to find out, this patient doesn't have really a physiological problem. The problem is this patient does not have a good sleep hygiene. Let's say a younger patient. This patient sleeps at 10 p.m. every night, Monday to Thursday, but come Friday night, they stay out. They go clubbing, etc., go party until 4 a.m. Then they go to bed, wake up at 12 p.m., and then they go out again Saturday night. And by Sunday night, they try to sleep early. So that's not going to work. The issue here is circadian rhythm issue, right? The issue here can be mitigated by just sleep hygiene or CBTI, cognitive behavioral therapy, right? These patients, when they have these types of habits, they end up with insomnia. And so the way to correct that is not through CPAP titration or additional sleep studies. They require guidance on CBTI, right? And then in addition to this, interpretation statement with diagnostic impression. So doctors will interpret the sleep study, will say this is a normal versus abnormal study. If it's normal study, they'll still have their recommendations. Maybe this patient has normal sleep study, and then they recommend for this patient to have a talk with their hygienist, a sleep hygienist. Okay. Or the study is abnormal because this patient has moderate sleep apnea, or recommend split night, or provide this patient with an auto PAP machine, etc. Or maybe the patient can have options to wear an OAT, an oral appliance therapy device, or an implant or medications, whatever is the appropriate treatment plan for this patient. All right. Then clinical management based on the diagnosis. So you have these types of patients and you have these types of management. For OSA, gold standard is PAP therapy. If they suffer from high BMI, they usually add the weight management and then positional therapy. Some patients just have apnea on supine. So when they stay on their side, they don't have any apneas. So they don't need CPAP machines. They need now positional therapy, which you can just use pillows, or there are devices that the patient can put in at night so that they can't sleep on their backs. Central apnea requires evaluation for cardiac and neurologic causes. Then consider ASV titration. ASV also has a prerequisite. Just a note, right? There is a chapter dedicated to ASV. discussion. It's on the advanced titration, and I already have a recording for it that you can watch. ASV patients must be cleared by doing a checkup on their left ventricular ejection fraction, right? Their LVEF must be at least 40 and higher. If their LVEF is less than 45%, the ASV is contraindicated. So this is an exam question. Make sure that you know this. And not just an exam question, but as a tech or as a future tech, you must know this. You can't just put everybody on ASV. Everybody that has central apnea. It's a big no-no because there is a mortality issue with having heart failure. Then you have narcoleptic patients. Narcolepsy usually is treated with pharmacotherapy, Dafan sodium oxybate. These are your mostly used medications for narcolepsy. RLS or restless leg syndrome is not exactly periodic limb movement disorder, but they are related. They are related. Usually, anybody with issues with periodic limb movement or RLS, they have iron deficiency. So they share the same therapy, which is giving them ferritin or iron. And insomnia, as I mentioned just a few minutes ago, can be treated with CBTI, cognitive behavioral therapy for insomnia. And this includes sleep hygiene education. What's important after patients have been seen, perform the sleep studies, be given their report is that they have to be managed. Follow up immediately with PAP therapy patients within the week, within month, not longer than that. Because if they fall and not use their PAP machine within the first week, that's an indication that they will be non-compliant patients. And you don't want them to be non-compliant because then their apneas won't be treated. And you always have to desensitize patients that are suffering from anxiety when they use their PAP machine. These patients, you have to call them back. Right now, here in the US and in some parts of Southeast Asia, you can monitor the patient's usage of their PAP machines remotely without having to call the patients in. You can log in, you can see the patient's usage. Did they use it for 4, 5, 6 hours? Did they have apneas? Do they have leak? You can monitor these patients remotely. So you don't have to call the patients in and ask them these questions. You will already know, and then you can already formulate what interventions you need to do. You discuss this with your doctors or with their sleep providers, and then you call the patient in and make adjustments. Okay? Do you need to lower the pressure? Do you need to address the leak by switching their masks? Okay. So then you also have to call in some patients who suffer from anxiety. They can come back into the sleep lab and you can perform a 4 to 6 hours called PAP nap. PAP nap is done during the day. You let them try different masks. You let them try on lower pressure until they get used to it. So you'll spend a good 4 to 6 hours with these patients just to alleviate their anxiety using their PAP machines. And then you encourage communication between yourself and the doctor and the patients. That's how you can clinically manage these patients. Once you have established that and your patients are compliant, using the machine appropriately, no issues with masks, no issues with leaks, they're using the device every night, using it for more than 4 to 6, 7 hours every night, these patients can then be followed up after 6 months or yearly after that. All right, special populations, pediatric, those with developmental needs. A caregiver must be there, okay, and very difficult to work in children's sleep lab. They pay high. I can tell you right now, here we have Chalker Children's Hospital in Orange County. We have CHLA, Children's Hospital in LA. The wait for these patients to get a sleep study is 1 year. And it's because they're difficult to handle. And typically it requires special types of techs. Okay. And usually pediatric sleep techs are very skilled. They have my utmost respect. I've done pediatrics myself and it's very difficult. But some of these sleep techs, they don't want to do anything else but to work on pediatric patients. And the pay is really good. You can definitely get $45 to $60 an hour on pediatric sleep. Then you have geriatric patients. These patients require safety precautions. Their skin might be more sensitive, so you have to be careful how you put their sensors. They might need mobility assistance. They might need to call a lift team, LIFT. We have these in hospitals. But usually we call the lift team if the patient is completely non-ambulatory or if the patient is morbidly obese that we can't lift and we can hurt ourselves. And also for legal protection. We don't just touch patient, lift them. If you fall and you're the one lifting the patient, you can get sued. All right. You always tailor the environment approach accordingly. So that's why the very first chapter is on age-specific approach, because it's very important for us techs and understanding that part of our jobs. Role of sleep tech is ensure patient safety, accurate data acquisition, and ethical conduct. Remember that the patients rely on us, and we have a lot of not power but clout over what we do with the patients. We get invasive, right? We touch them, we get them exposed, we put electrodes on them. So we have to be very careful and have to be very ethical in how we perform our jobs. We should recognize quickly life-threatening patterns, severe desaturations. If we see SVTs versus seeing ventricular fibrillation or VTAC, we need to understand fully on how to identify life-threatening situations. And then we communicate verbally, non-verbally, through annotations with the patient, with the doctors, everything that we see. We are the eyes and ears of the doctors or the sleep providers all throughout the night. We spend a lot more time with the patients than with their doctors and nurse practitioners and physician assistants. We are the one who educate a lot. The patient's understanding of sleep can come from us majority of the time because we face them for a longer period of time. Summary of sleep study workflow. We verify the order, prepare the study, we start to record, we score the study, create the report, and then the doctors will interpret the studies and create a management or an approach for this patient. Then we can be a part of that clinical management for that patient moving forward. So we ensure that each step is accurate with the diagnostic studies. With that, we observe safety precautions, whether we're dealing with mobility issues, pediatric concerns, and then we collaborate among other techs or physicians and etc. All right. And here's my reference. You guys are amazing. You guys made it. Let me stop my share. Any questions? That is the entire RPSGT exam right there. We just didn't hit it on deeper level, but that's really the entire course. So I'm glad that some of you are able to experience and see this. Now, from here on, tomorrow, next week, I'll be giving a comprehensive exam to those who's been with us for the past month or 2 months, just to see an overview of their knowledge. But for those who have just started, then I'll meet with you next week or this week. I'll be available. So anyway, floor is open for a discussion, questions.